faculties. Faculties, we have stalwarts in the field of laparoscopy with us, Dr. P.G. Paul sir from Cochin and Dr. Manjula madam from Hyderabad, who will be speaking to us on topics like specimen retrieval and energy sources, very vital for us to perform a very safe laparoscopy. And we are privileged to have them here share their valuable knowledge and practical insights. As we all know, laparoscopic surgery is but with subtle different sound judgment and meticulous techniques. Today's webinar is so designed to simplify these concepts, enhance our skills, and reinforce our practices that improves patient safety and outcome. We also have a panel to make troubleshooting during procedures safe and simple. We have our moderators, Dr. Divya Narsimhan and Dr. Tarun Joseph, with their eminent panelists who will make it very safe and simple at the end of the webinar. I extend a warm welcome to all the delegates and request the active participation and discussion to make the most of this program. Once again, on behalf of OGSSI 2026 and the Endoscopy Committee of OGSSI 2026, I welcome all those logged in today. Thank you. Can we have Dr. Meenakshi do the OGSSI prayer?
Yeah, hi, can you hear me?
Hi, please.
Yeah, welcome you all. Thank you, God. In humility we gather. In gratitude we pray for the good things that you've given. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn, the courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you, Vanita.
Thank you, Meenakshi. It's my privilege to welcome Paul, sir, the chairman of Paul's Hospital, Kochi, India. Sir needs no introduction because he's been a teacher to most of the teachers today. Sir is a board member of ISGE. He is a elected mentor, the Society of Reproductive Surgeons, 1997. He has authored 2 books and contributed chapters on almost 20 books. He has published 34 papers and invited lectures. He has innumerable to his credit, and he is an editorial member and reviewer of reputed journals. It's an absolute privilege for us to have you here to talk about a topic sometimes we are stuck with and give your insights and inputs on how to retrieve specimen in different scenarios, sir. Over to you, sir.
Thank you very much. I'm very happy to be part of this OGSSI committee meeting. And can I share my slides?
Yes, sir. Please, sir.
Is it?
Sahidi, can you just help out?
Yes, ma'am.
My screen is not seen.
Not yet, sir.
1 second. Continue.
Sir, at first open the PPT and minimize it, sir.
I will just see. Is it visible now?
Not yet, sir.
Oh.
When you come to Zoom, there will be share option, sir. You need to click on that.
I did that.
And then entire screen tab, which is on top.
1 second.
And then again, click on share.
Lower down, the shares,
Share screen.
it's down or below. I just forgot. We have been doing all this.
Yeah, you need to click on the share option, sir.
Share option, but share screen is not. Okay.
Yeah, please click on that, sir.
Is it coming now?
Perfect, sir. Perfect. We can see the.
Oh,
Please
sorry.
make it full screen, sir. Thank you so much.
We are able to see your screen now, sir. You can
Okay.
show mode.
Sorry
Yes, sir.
for the confusion. All of us know that in laparoscopy, majority of the cases we have a big tissue to retrieve, and that comes at the end of a difficult or long surgery, and sometimes we get into trouble. And I will be sharing some of the methods I used. It must be more than one, and it will be few videos. This is the commonest method. We remove a specimen. We put this in a bag. We normally have different designs. This is, I think, a locally made bag, not made by me. It's a professional one. And one important thing about retrieving the specimen through the port is you have to enlarge the port. Many times you can just pull out the bag, but specimen removal will be very difficult. So I normally use an 18 millimeter dilator over a straight road, and then you pull out. And if the contents are liquid, then it's comparatively straightforward. You can decompress the cyst and then automatically. But anyway, you have to enlarge the primary port. And I normally use a 5 millimeter scope from one of the secondary ports. That's why you can see that my video is comparatively less lighted because it's a smaller telescope. So we have to close all these dilated ports. And this patient also had an epigastric hernia, which she wanted me to repair if possible without mesh. So I just opted for closing the small epigastric hernia. We have to reduce the content and then release any adhesions left behind. And then you can close this either with a Proliene suture from inside, or you can use a port closure needle itself to close this. I will speed up this. It's completely straightforward procedure. And before completely tightening this, probably you have to reduce the intra-abdominal pressure so that it will not be over pressurized. Another important method is colpotomy. You can use a bulger in the POD, either a CCL extractor or a sponge on holder or whatever instrument you can use. Sometimes I use a 10 mm trocar itself to puncture without any instrument from above. Now you can see the CCL extractor, and you have to put the endo bag. This was an adnexectomy plus myomectomy. And there are several designs of endo bags I already mentioned. This endo bag is like a basket. So it keeps it open once you just push it inside, and you keep all the specimens inside. Colpotomy is actually comparatively straightforward, and you can very easily. She had an appendectomy also along with this procedure because of the endometriosis. And you can see the site, and there is a specimen which we have kept in the POD. This is the adnexectomy specimen that also is kept inside. And another myoma also we had removed along with this. And once you pull the bag into the trocar, it automatically closes. You can see that I am just pulling it out. These types of bags are comparatively costlier. I had few samples, that's why probably I might have used this. You can close this afterwards vaginally. Another method of performing myomectomy, when you have a huge myoma or multiple myomas, sometimes performing completely laparoscopically may be very time consuming and associated with the more blood loss. So there's an old video, but you can see that the principles, this mini lap myomectomy. This one is you perform a laparoscopy, you identify all the myomas, you inject vasopressin and make an incision, and afterwards you put a myoma screw and pull it over to the suprapubic port. I normally make a vertical incision of 3 or 3.5 centimeter. You have to be very disciplined for this process. You make wedge of tissues so that the myoma keeps on coming. And also you should make sure that you are, I think there is some net problem, it's becoming slow. A good pair of tenaculums are the best one, or towel clips are the best instrument to hold on to this tissue. You make wedges and automatically it's a time consuming, but definitely the whole myoma comes out, and you take this coring technique. You can use a wound protector, or this case an old one. And it's very important that when you remove the final part of the myoma, you must pull out the myometrium also along with that. And then it is followed by closure of the myometrium in layers. Sometimes you are made a very stingy incision, and putting back the myoma will be, the uterus will be sometimes difficult. And once you finish one myoma, then you go back and inside. I think many of you must, although we all started this earlier, nowadays people are very reluctant to perform this, and you can see the final result, just 3 centimeter. This is a recent one where
Going out here.
the same principle is being used. You make the incision and just minimal enucleation is being done. Here you can see the wound protector, and this is the end result. All of us know that when you have very large uterus, 24 weeks, 26 weeks, we still try to remove the specimen vaginally. I think in Chennai, all of you are experts in vaginal surgeries. The same principle. I normally use a tenaculum and cut from 12 o'clock to 6 o'clock on the right side, rather than cutting all around. The advantage is surgeon don't have to move the head from left to right, and I always look at the right. And once you cut that, you rotate the specimen and bring down as much as possible, and then again cut from 12 o'clock to 6 o'clock. This process is continued. There is no hurrying up. It's very important that your two speculums should protect the vitals, the bladder and the rectum. Sometimes the assistant is careless and does not put the speculum deeper. You can actually injure the vagina or rectum. So be careful that you ask the assistant to keep both both speculums deep inside. unless it's more than 10-15 centimeter, any myoma will come out slowly as you go on doing the surgery. I think in-bag morcellation has now become a standard of care if you are planning to do morcellation after laparoscopic myomectomy, because all of us know the most common complication is parasitic myomas. I think there are many reports. We also had several reports earlier. And this is one reason why you should do it because it's not very rare. Because now after many years, 20 years, we are doing either for a hysterectomy and you find a lot of parasitic myomas which were not actually symptomatic, only very large ones, symptomatic ones, you identify, otherwise they remain inside. And now you should not do any open morcellation. And although the rare occasional malignancies you come across once or twice in a year, so open morcellation should be totally abandoned. And this morcellation, I normally use an 18 millimeter morcellator because 15 millimeter morcellator is actually makes very small fragments. This is another colpotomy, a 21-year-old unmarried woman with abdominal mass, and MRI showed a 10 centimeter solid and cystic mass with a 5.2 centimeter enhancing solid component. Her CA19 was 103. Her aorta index and ORATs were slightly on the intermediate risk of more than 20%. But the patient insisted on a laparoscopic removal, so we planned for an adnexectomy, staging biopsies, and infracolic omentectomy. This was the ultrasound finding. You can see the solid one, and you can see the large solid mass. So without performing or manipulating the ovary, we identified the ureter and we did the adnexectomy first. There was no ascites, no secondaries, so we performed a right adnexectomy for this 21-year-old young woman. And we also performed a staging biopsies from the subdiaphragmatic space. The harmonic comes handy for this. Multiple biopsies from the peritoneum, paracolic gutter, and pelvis were taken. An infracolic omentectomy also was performed because the high suspicion of malignancy. So whatever we do, laparoscopic laparotomy can be performed. The only problem is removal of the mass intact. So we performed a colpotomy. You can see the colpotomy being performed. Or a CCL extractor. And we actually needed a big endo bag for this. So a Lima's vaginal bag was introduced and the whole mass was inside. A 10 mm claw forceps was inserted and the bag, mouth of the bag was the full mouth of the bag was brought outside the vulva, and the specimen had to do few cuttings to remove it from the vagina. This is the end picture. Histopathology was stage 1 mucinous carcinoma of the right ovary, and all the staging biopsies were negative for malignancy, and the oncologist's opinion was taken and advised to have just follow. And to conclude, specimen removal, although the last step, one of the most important part of the laparoscopic surgery, the commonest is we enlarge the primary port and use a 5 mm scope, which we pass through one of the secondary ports. And usually smaller specimens, this is a quite nice method. When you have very large myomas like 28 weeks, 30 weeks, mini lap myomectomy actually saves the time because the same morcellation as well as removal of enucleation of myoma comes simultaneously, and even the closure becomes second step of this procedure. Vaginal morcellation is the one which all of us mostly use for TLH, but myomectomy also it can be done very safely. And in-back morcellation should be done if at all you plan for open morcellation. So good planning and counseling, especially young women, where when you perform a colpotomy, definitely you need to counsel the patient for a vaginal procedure. Thank you all for the patient attention. Once again, thank OGSSI for this opportunity.
Thank you, sir. Thank you for that elaborate discussion on the various specimen retrieval techniques. Very rightly, you brought out saying that when you have very large myomas, 20 plus centimeters, it's better to do a mini lap myomectomy rather than, always sitting and trying to, we can't bag that specimen also. And then we're always worried about doing an open morcellation, and the time taken for that morcellation is really too much. That very rightly said, sir. We have a few questions in the chat box. Can I take them now, sir?
Yes, go ahead.
How does the uterus stay anteverted when using colpotomy specimen retrieval? Is there any special equipment? I think they want details about the CCL extractor.
Normally, you can just use another instrument from the one of the port and just lift up with that instrument. You open the instrument and use it as a instrument to lift up the uterus. And you can put anything bulging into the posterior fornix. But that should be done by somebody experienced, because to my knowledge, there are 2 occasions where people put this into the rectum and open instead of in the posterior. No, it can happen
Yes,
because
it should be between the two uterosacrals, because I've had one occasion where the assistant was looking at the monitor, travel all the way till the ureter course.
so this has happened twice to my knowledge. They actually put it into the rectum. The assistant nurse put it in the rectum, and once it bulges, you don't know what it is. Then you open the rectum, and then only you identify.
The next question is, what is the length of incision for the mini lap?
3 to 4 centimeter.
3 to 4 centimeter. You can cut the vessel. You can use a retractor, which will give you more space to lever it out.
Right.
Posterior colpotomy incision, ideas and tips, sir. Another delegate wants more tips on how to do the posterior colpotomy incision. I think they want the landmarks and how to do a safe colpotomy.
That's a very important thing, because as you mentioned, first you identify the uterosacrals, and you must put something into the posterior fornix and bulge that area. And when you have endometriosis, then this becomes little
Very
tricky
tough.
because the rectum will be pulled up. If there is only minimal additions, definitely you can release and go. And if POD is completely obliterated, I don't advise you to perform this procedure. Otherwise, you just identify the limit of the rectum, and you should not be very close to the uterosacral because you will not get enough space. I normally put only a transverse, but some surgeons advise you make a cruciate
Even I
incision.
do a
Uh,
transfer.
but I don't like a cruciate incision, and most of the time, once you have a specimen, you pull it down. Actually, we can put 2 small speculums below and above, and the vagina stretches very well. So the whole vagina you can use as removal. So even quite big specimens can be removed by colpotomy.
A good positioning, like an extended lithotomy, the little changes in position and all that makes the perineum more accessible for you to do the retrieval much easier. Thank you very much,
Is there
sir.
a chance of wound extension, sir, when we do through a colpotomy? Is there a chance for lateral extension or something like that?
Oh, I never had one because if you are in the correct position, if you are very close to the rectum, probably it can injure the serosal and all those things. But you, by stretching this area, you can clearly identify even if it extends where it can go. So I don't
Okay.
think it should happen. Very unlikely to happen.
Okay.
Thank you, sir. Thank you so much for sharing your knowledge on the various retrieval techniques. So one more question. Many a times we try and retrieve it, but there are a lot of times we miss a specimen inside the abdomen, especially when we do multiple myomas. They just get lost in between the bowels. Any other technique other than the springing and keeping a count, asking somebody to be very meticulous about the count? Is there any other technique, sir?
When you have multiple small ones, it's better to keep a small endo bag inside and put it inside.
Okay.
Because large ones I normally keep below the near the liver. It cannot go further. But anything less than 3 centimeter and all very tricky. You can get lost and you will never be able to retrieve it. Even POD also, when we change, sometimes it get lost. So if you have more than 3, 4 smaller ones, definitely an endo bag, I keep it in the right left fossa, and
Okay.
that's how I go ahead.
But you do the enucleation itself, you take the bag inside and start packing them inside the bag, sir?
Yes, inside the bag.
Okay.
Previously, I used to, as an experiment, try to suture one by one, like what do you call your necklace,
Yeah,
something
string them
like that.
out and then pack it.
Park
So,
it.
endo knife, your thoughts, sir?
We had used it earlier, but nowadays I don't use.
Looks a little scary because goes sometimes without control. How would you
That's
recommend
true.
that,
Yeah.
sir?
We had used it earlier in the beginning, where moscillation and those things were not standardized.
Okay, sir.
No
So
still.
the mainstay is any myoma or large uterus where there's a suspicion should be inside a bag. The power modulation should be done only inside the bag.
That's true.
I'm sure sir would always recommend only that. Thank you so much, sir.
Welcome.
We now move on to the next lecture by Manjula Nagani Madam, Madam is having the Padma Shri Awardee for 2015. She is the co-founder of Pratyusha Support. She is a Guinness record holder for having the highest number of fibroids removed from a single patient, 84. We really need to also ask Madam how she, talked them inside and got them outside.
I was
She's a clinical.
will stop rest of the things, but Vanita, I just wanted to add to what Paul sir is telling. Endo knife, you will not have a stability of the fibroid to use, and so it goes round and round. So in 2005-6, endo knife were used, but after that nobody uses endo knife much.
Okay, ma'am.
So let us go ahead with my next talk.
Madam is a real walking, talking legend. That's what I can always say. You are in trouble, you can text her and she's always there with a reply. Welcome you, ma'am.
Thank
To
you.
talk on the various energy sources. Energy sources is which is revolutionized minimal access surgery. And everybody feels once you have the costliest one, your surgery is going to be safe. And Madam is really going to throw light on the various pitfalls and the advantages of various energy sources. Over to you, ma'am.
Thank you, Vanita. But like you said, if you take a harmonic and cut a ureter, it is not the fault of harmonic. So it is the technique and technology, both goes
Yes,
hand.
ma'am.
So I want to talk more about the practical aspects about it. With laparoscopy, we have come in a long way where we have started doing a lot of minimally invasive approaches. And we have to look at this particular slide for 1 second. Where the center of the whole thing, or the whole surgery which we do, we have the device tissue interaction. On the top of it, as us, surgeon, we decide our training, our technique, our experience with the equipment. Then comes the patient factors. If she has a comorbidities, they're having fever, where the amount of water in the cell is less. These are very, very important in compliance with the care what we are doing, telling them. And then the human factors will be there, interaction between the device and our ergonomics. We get tired. At the end of it, we just want to do one particular thing. We might end up having injury. So then the facility, what are the things our hospital is giving us? Are they giving only scissors or bipolar, unipolar, or do we have advanced equipment is what is important. Next, insurance is equally important. At the matter of if the insurance is not going to cover with harmonic, you have to do with monopolar, bipolar, how to make it safer. So there are only two rules. One is safety of the patient. Second is comfort of the surgeon. But over time, lot of advances has taken us in a different way. So let me take you all through a practical aspect of what is important in energy sources. I'm not going to tell you a lot of theory, but what is exactly important. So by the end of the lecture, you will understand how exactly we should look at in our theater. So problems come not because we want to cut, we want to desiccate or coagulate. Problems come because the non-targeted tissue is injured. We are not interested in cutting the ureter, but it gets injured. So let me ask you some questions to start off. Did we ever wonder that the patient is a part of the whole electrical circuit? But why am I'm also part of the circuit? Then why am I not getting electrocuted during electrosurgery? What is the difference between electrosurgery, cautery, and the electrocautery? And what is the coagulation? And how do the vessels actually seal? And which monopolar, in the monopolar, which one is safer? Is it the coagulation or cutting? And out of monopolar, bipolar, which is again safer? And between the traditional and advanced, how are they different? How can we make our traditional bipolar look and behave like advanced? And why are we always worried about lateral thermal damage? And which energy modality? Is it the unipolar, bipolar, harmonic, or which one? Which will cause more thermal injury and why? And what is the maximum vessel size you can coagulate? So let us finish understanding and see what we can answer. So why don't the patients or us get electrocuted even though we are a part of it? What we need to understand is after a particular frequency, there is no NMJ stimulation. So above 100 kilohertz, electricity just passes through us. So, but in the electrosurgical equipment, it is 250 and above what we have. So the electricity passes through the patient, but the patient is not electrocuted. And basic principles is water and collagen. The amount of water and collagen in the cell will determine whether it is going to be charred or burnt or it is going to be coagulated. So water content is the main determinant. If the patient has fever, water content is less. That means it takes very less time for it to get charred faster. So we need to remember that organ system, age, illness, inflammation, temperature, all makes a difference. So it is the balance between cutting and coagulation, which is a technique. So cautery, we use this word very easily, but cautery is surgical use of heat. So what we do is never a cautery. What we are using cautery in gynecology is only with copper sulfate, where we are using heat as a thing. So it is a chemical cautery which we are using. Electrocautery is, again, there is no electricity inside the patient. It is a tissue, any instrument which is heated by electricity, and that is being used. It is something what gastroenterologists use to take out the polyps from the GI tract, or what there are some scalpels, that is electric scalpels, which are available battery operated. So these are things which are electrocautery. What we use in our ORs is electrosurgery, that is use of alternating current which is passed through the patient to coagulate the tissue. Fundamentals. This is one thing all of you remember. By the end of this lecture, I'm going to make you all remember that it is three things which are important. That is compression, temperature or heat, and time. The more we compress, less time is taken to get to the coagulation what we want. That is the temperature is going to be reaching that time. So three principles, fundamentals is compression, heat, and time. So in this slide, what is important is till 40 degrees centigrade, there is reversible tissue damage. 40 to 80, it is irreversible tissue damage. Protein denaturation starts. 80 to 100, you can see the arc, the way it goes up, means inversely proportionate to the temperature. It's the shortest time, and the temperature is going to increase fast after 80 to 100. Collagen denaturation happens in 100, and between the 100 to 150 is the desiccation. So whenever we want to do laparoscopy, we want it to be in desiccation. Means after 150, it suddenly goes up to 400 degrees, causing carbonization or charring. So we don't want that to happen. So the less time is taken to become charred after 150. So our aim is to keep the temperature between 80 to 150. Advanced bipolars keep it around 100. So in our traditional bipolars, we have to try to keep it 100. 100 to 150. How to achieve it, I will tell you. So when there is less water content, shorter sealing time is done. So what does the electrosurgery do? It cuts, it fulgurates, it desiccates. Cutting is by monopolar only, where the tissue doesn't touch and there is rapid heating and there is an explosion of the cell. Fulguration is also again by monopolar and it's short duration, high voltage. But desiccation is by both monopolar and bipolar. So let us see what are the energies we used in laparoscopy. One, electrosurgery, monopolar, electrosurgery, bipolar, lasers. Mechanical is suturing, scissors, stapling, and ultrasonics. So basics of electricity, what we use in surgery. Clinically, what is important is any energy goes through path of least resistance. And then when one thing in laparoscopy is in the tower, we are not going to change the power. We put the watts as 35 for bipolar, 45 for unipolar. After that, we do not change.
Manjula ma'am, excuse me, ma'am. I request all the others other than Manjula madam to please mute themselves. Sahiti, somebody is unmuted. Please mute them, ma'am. Ma'am, please go on, ma'am. Sorry, ma'am.
So the second point is we don't change our energy source power. It is either 45 for unipolar or 35 for bipolar. So what is variable? What is it changing is voltage. I'll explain with videos. Injury, and the third point you need to understand is injury is directly proportional to current density. Wherever you are touching, how much is the density around that? That is what is the injury. Circuit has to be calculated and current concentration is the place where complication happens. So let us go one by one. So if you start doing, if you see this picture, once the energy is going, the tissue around it will start getting heated, resistance increases. Once the tissue resistance is completed, if you still go on pressing on the foot pedal, the energy starts going into the least resistance, means you're allowing the lateral thermal damage to happen. So you need to just do pulse therapy. You need to say 1, 2, 3, stop. Allow the energy source to come back. Again, do 1, 2, 3, stop. So lateral thermal damage does not happen. So least resistance is what you need to understand. Once it coagulates, stop it. Don't continue the pressing of the foot pedal after the desiccation is over. Desiccation is the point where the intracellular volume water starts shrinking. You should not wait. It is completely becomes dry. So once the cellular water starts shrinking, that is a desiccation point. So here, if you see, you keep hearing to so many of the people saying that blend 1, blend 2, blend 3, pure cut, and coagulation. So what is important is when we talk about this, it is the waveform. How many times it is silent, how many times it is acting. So once our power is completely stagnant, it is a voltage which keeps variation. So when you put pure cut, it is 100% of the time normal, on. That means the same amount of electricity should go in that particular 100% of the activity. So voltage is less. So side effects, complications are less. The more you make it blend or even coagulation, the activity is only 6% of the time, 94% of them off. So voltage is high. So the complication rate is high. So what we understand from here is pure cut is the safest unipolar energy source. I hope this point is going into the brain. So coagulation current is more dangerous because the voltage is high. So what we understand from this is pure cut is the safest, and the more you go towards blend or by coagulation, it is more dangerous. Third, in the same thing, I want to show you some experiments which we did way back in 2006-07. So this is the cutting current which we are using. The depth you see, you are continuously using. Now, to get the same effect, if you are using coag current, you don't get it. So you have to use it 2-3 times to get the same effect. So to get the effect, the amount of the energy or what we use with the cutting will cause the best effect with the least damage. So the number of times you have to do with coagulation is more. If you take the same thing as injury, now first what we are using is coag. You can see the finger which is going to coag. So 1001, 1001, 1002, 1001, 1003, 2, 3, and 4. Then again, if you say 1001, 1002, 1003, 1004, 1005, 1006. And then if you see the lateral thermal damage with coag, and now you see the cutting current, 1001, 1001, 1002, the lateral thermal damage is less. So if you're continuously using a cutting current, lateral thermal damage is less. If you are using a coax current, lateral thermal damage is more. This is the point you need to understand. So next comes injury is proportionate. What do I mean it? You see the unipolar tip, it is going to touch at one point. So the amount of damage which is going to happen because of the concentration is less with unipolar. The same thing when we use bipolar, it has two poles. So the current which is concentrated is more. So tissue damage is proportionate to the power applied. So greater with bipolar than with monopolar with the same current use. That is the reason we have to put the bipolar electricity as 35 or even less and monopolar at 45 or less. So till now, the take-home messages are: one, path of least resistance. So don't continuously press the foot pedal after the desiccation point comes. Second is coag is more dangerous because the voltage is higher. Third, bipolar is more dangerous because the electricity is going to concentrate on a higher, larger volume. If the same energy, same this thing is used. So we use the current lesser with bipolar and more with monopolar. Next is circuit has to be completed. So monopolar, patient is a part of the circuit. Bipolar, patient is not a part of the circuit and the tip is a part of circuit. Now to be completed, we have a grounding pad. We don't want this sort of energy. This is what is the active electrode, passive electrode, which we taught. Now, patient plate is something which is very important, which is the negative pole or passive pole. Current density is inversely proportionate to the contact area. So, smaller patient plate means more current will be concentrated there. So, more damage. So, you need to use the patient plate, which is as large as possible. And it should be on the muscle, not under the buttock where the liquid will come in between and the contact area is going to be less. So, it should be on the anterior part of the thigh, away from the liquid water or any betadine which goes inside, and complete contact, and current does not flow uniformly. At the edges and corners, it is more. So we should put in a way that longer edges point towards the active electrode. So it's the large silicon rubber plates, that is the best thing we have to use. And not all generators are state of art. So we have to remember the fifth important, which is the most important point. So till now, we got the 4 points, which I always tell. So patient plate is very important, and injury is directly proportionate to the concentration which we use, and these are the things. The fifth one is function of variable resistance of the tissue where the current is going to get concentrated. Means if you are using the electricity in a bubble, it gets concentrated faster. You use electricity in a muscle like uterus, it gets concentrated slower, less concentration of electricity. So it's a function of tissue desiccation.
You said something?
Density. So let me show you this video. So if you take this and you are applying the electricity on this muscle, whereas electricity is going and concentrating here, you're not touching it, but it is going to concentrate there, and then that complication happens. This is what happened when the unipolar energy was used, law of thoughts, and a small adhesion is there, and that adhesion is adherent to the diaphragm. The electricity goes through this adhesion and goes and puts a hole inside the diaphragm and causing the pericardial damage, tamponade, and that led to a biggest complication of the surgeon and a lawsuit in UK. So we need to understand these 5 basic points. Next, what are the complications we see with monopolar? Direct coupling, we know, one instrument touching the other. Second is capacitive, which is the most important and unknown problem which we have. Fourth is insulation failure, which is again because we start using instruments which are outdated, which are having holes. And grounding pad failure, which I already showed you, alternate site burn, and surgical fires. So what is important, why are we talking about this in laparoscopy, is that laparoscopic environment is different. There is a presence of insufflating gas, which has low heat capacity. So instruments do not cool faster. In open surgery, the environment is open to the intra-abdomen. It cools off very fast. Then we are using cannulas. So limited access to the tissues will require the use of cannulas to pass the instruments to it. So limited field. We are operating near the uterus. You don't know if the energy is going through some addition towards the liver or what. So these are all the things which are potential electrosurgical hazards. So direct coupling is one, inadvertently you're touching one instrument to the other, and that instrument is touching something else. The capacitive coupling is the most important thing because we start using lot of steel cannulas. That is the most dangerous thing. Wherever you want to use energy source, that particular one, please use plastic cannulas. Why is it so? The capacitor which creates there will cause a capacitance there, because two conductors, when separated by non-conductor, also becomes like a conductor. The higher the peak voltage, the greater the chance for capacitor to discharge. So look at this in this video. Here, there is a bulb. There is electricity inside the wire. Wire is just going around the bulb and the activation is done in the air. The two things which are happening here, activation, there is no way for that electricity to go because it is happening in the air. Here also activation is happening in the air, but still the bulb is not getting activated because it is not going around it. So what we need to understand is, if a capacitor conductor is there and there is another conductor, if it is separated by a non-conductor, here there is a plastic thing which is separating it, but that also becomes like a capacitor. So metal trocar cannula around an active electrosurgical instrument is something we have to know. What in the open surgiments we used to see is, the nurse used to tell, madam, this is the instrument on which I'm using this cable, and later the thigh got injured. How does it happen? Now imagine, this is the patient plate and that is the thigh of the patient. Now the nurse has turned all around the energy source and you're operating somewhere else, whereas this instrument is touching the thigh of the patient. So what's happening? Energy is going to be redirected. The monopolar electricity is being redirected to the thigh of the patient, and that is burning. So the fallacy here is, one conductor around the other conductor. Second, the activation is done without the showing the pathway for this unipolar energy. Means that energy is not having a path to go, so it is taking an alternate pathway. So open circuit activation should not be done. Second, low voltage is what we have to put so that non-contact activation does not happen. So low voltage cut is the way to go, and plastic cannulas will decrease but does not eliminate. So of all the cannulas which you use, the one where energy source is being used, please use a plastic cannula. So single site energy, that is the reason it has gone out of vogue, because there's a lot of incidents of monopolar electricity injuries, potential hazard for the bubble burns. So except Korea, most of the countries do not use it. Insulation failure, I told you there's a hole through which it can happen. Smaller the defect, higher the current density transfer. Rest of the things is whenever they contact with the metal, surgical fires. I have not seen a surgical fire except in Grey's Anatomy. So previously, when alternate site injuries used to happen, it is because of the earthing, that is ground reference system, which used to be there. But now we have an isolated system where until the path comes back to the generator, it does not get activated. So do not compromise with the generator system. So do I mean that bipolar is very safer? One side I said bipolar is more dangerous than unipolar. The same amount of electricity is used. And one side I'm saying a lot of complications will be there with unipolar because of the capacitive coupling, apart from the rest of the things where we are careful. So bipolar, have a look at this. Look at the bipolar. There's a continuous thing and the energy source is going later. Why is it happening? Because after the desiccation has happened also, we are going on pressing on the foot pedal. Now have a look at this. If you are using pulse technique, there is no lateral thermal damage. So this is what I say, if you are using your traditional bipolar as using in a pulse technique, like the way advanced bipolar happens, then your lateral thermal damage is less because current concentrates at lesser and low voltages. So only effect that bipolar can do is coagulation. Bipolar cannot cut. So technique sensitivity is what we need to understand. So like I said, it's the compression, the temperature, time are the three most important things for any sealing, whether unipolar or bipolar. So to avoid thermal injury, we have to use cutting current in unipolar, compress the tissue so that the water inside the tissues can go off and it reduces the blood flow and lessen the heat sink. Pulse the energy on and off every few seconds so that the energy source which is going lateral will come back and again it starts. Allow the tissue to cool in between. Put a cool irrigant fluid on it and judicious dissection of structures and separation before update. So what is advanced bipolar? The difference is here compression is done by the generator or by the instrument. Mechanical cutting is what we do with traditional. Here the cutting is done by the instrument. Pulsed electric current is done by instrument here, whereas in traditional we have to do it. Adaptive controls where everything stops at 100 degrees is by the instrument or generator, whereas here by using pulse technique, we will stop at 150 degrees. So we can make our traditional bipolar into advanced bipolar. So what's happening here? I'll just go a little faster here. So this is the Ethicon NSEAL. So what is happening here is a piezoelectric positive temperature coefficient and the piezoelectric method which there. It moderates the heat at approximately 100 degrees. The pathway which is happening because of this is all these are the cellular model where we show the they disintegrate when the temperature reaches. So if it is an inside out technology where it gets heated in the center first, then laterally it goes up lateral. So once the temperature becomes 100, the electricity stops. So it's outside in. So once the positive temperature coefficient approaches, then it stops. Once it starts cooling in, again the ions join and it starts forming where the electricity can go. So this is what happens. And if you take it at this, here it is now outside becomes 100 and inside is still 45. So once the outside temperature becomes 100, electricity stops passing there. So there is no lateral thermal damage because next comes the coagulation of center part. So this is the way it happens. And once the whole 100 degrees comes, the whole thing is coagulated, then the cutting starts happening. So once this is done, it gives a signal and you can see all the ions are disrupted and then the cutting starts happening. So ultrasonic is nothing but it allows cutting, coagulation, avoids the effects and offers significant flexibility because what we can do. This is the way original generator was Gen 04. Now we have Gen 11, then we have the advanced both NSEAL and with the generator. So what we are looking at is electrical energy, which is coming to piezoelectric ceramic disc, then transferring the electrical energy into mechanical energy, where 55,500 cycles will come per second at blade tip. So this is how there is the electricity will not pass through the patient. So there is a two effects, that is coaptation and there is coagulation which is happening. So it is the transfer of mechanical energy is when there's coaptation, breaks the hydrogen bonds. Coagulation happens at 100 degrees again here. Then the cavitation effect happens at the tip of the blade. To find it, the food fluid will start vaporizing. The vapor will start forming the tissue planes and quick and localized effect will be there. So if you look at the video here, there, one is a stable form. The other one is the one blade, the active blade is the one which will go 55,500. You can see the cavitation effect and the way the separation of this thing happens. The take a harmonic and start cutting and expecting it not to cut, it does not happen. So key differences will be the temperatures with ultrasonic is definitely 100. Electrical energy, if you don't use properly, like the pulse technique, it can go up to 300 to 400. Lateral thermal damage, because with harmonic it is 2 mm and even the advanced bipolar it is 2 mm, it can go up to 6 mm to 1 centimeter if you don't know what to use. Vessel sealing is now almost 1 cc, 1 mm, 1 centimeter with everything. Cavitational effect will aid in plane dissection. Smoke is less. Safety is no electricity. But remember, you take a harmonic, cut your ureter, don't expect it not to cut. So, but it is multifunctional, cuts, coagulates, grasps, dissects, back scores. So 5 factors which are important is tissue tension, blade sharpness, time, power, and grip. So these are the settings which I use. If I want a coagulation effect, because I can use the coagulation of harmonic, I'll put a minimum power setting. That is 1, lighter grip, less tissue tension. When I want it to be cut, it will be at 5, and stronger grip and more tissue tension. So comparison would be, like I said, less than 100 is harmonic, 100 to 150 is the advanced bipolar. Electrosurgery, if not used properly, is 150 to 400. COT laser is more than 350 if not used properly. So lateral thermal damage is maximum with monopolar and bipolar. Ultrasonic and the advanced bipolar is the least. So this is the same thing. So despite relative ease, this monopolar is never predictable. It causes significant damage, unreliable seal. So, but ideal is something, no smoke. What we want is minimal charring, easy to use, easy to convert. The best thing is only the harmonic, which has accomplished because it causes the coagulative cutting. So coming back to our questions, why don't we get electrocuted? Because the electricity, all the surgical experiments will go beyond 250 megahertz. The difference between electrosurgery, cautery, in the electrosurgery is what we use in our hospitals because the electricity goes through the patient. Coagulation and how to vessel seal is always the interlink between the compression, temperature, and time. Pulse technique is few seconds we use. Temperature does not go beyond 150 if you use pulse technique. And the compression manually we do it. Monopolar waveform cutting is the safest. Traditional and advanced, the differences are compression, temperature, that is the modulation of the temperature, and the time use is done by us, and cutting is done by using different instrument. Lateral temperature is dermal damage is important because of the vital organs, especially lateral to the uterosacals, which is there, that is ureter. And more thermal injury is if the same amount of electricity is put, it is the bipolar. And the maximum vessel size, it can go up to almost 1 centimeter. So today, it is, I think, few reasons for all of us to do any open surgery. So it is all about the technique and technology. So we should have a control and precision over cutting, coagulation. Improved safety profile and better outcomes are what we are looking. And we are not looking at shorter OR times, but that is equally important to be a safe surgeon. So thank you, Dr. Vanita, for giving me this opportunity.
Thank you so much, ma'am, for covering all the points in a nutshell. Thank you so much, ma'am. A few words on the very commonly used instrument, the Indian-made shearer or the sealer. We really don't understand whether it's a monopolar instrument or an advanced bipolar instrument, but that's got become the magic wand in every laparoscopic surgeon's hand today.
They claim to be an advanced bipolar. That is what they do. So, like I said, if
So
it's
one concept which I don't understand is it also cuts and seals
yes, that is the reason.
without a mechanical knife.
That is why that cuts and seals. That is the reason where they claim it to be an advanced bipolar. Because the four things I told you different. One is compression, temperature, time, and then comes the cutting. If it is cutting, that means it is an advanced bipolar. The regular bipolar, the only thing is compression, temperature, time, and only coagulation is its work. Cutting is not its work, traditional bipolar. If it is cutting, it is the advanced bipolar.
Okay, ma'am. Ma'am, we have one or two questions for you. What do you prefer for wall cutting, ma'am?
I prefer to use unipolar because unipolar cutting is what I use because I am a hardcore harmonic person. So I really want to use my harmonic because the MRP right now is 88,000, 84,000. Okay, one instrument. So I have to at least use for 8 cases so that I can divide it for 10,000 for each patient. If I use Allen, maybe for more cases. So I use harmonic till I come to the vault. And once I have a safety profile of pushing the bladder down, ureter lateralized and all, I use a unipolar cutting to just go all around and cut it. So that lateral thermal damage is minimum. Use it like a knife. Don't use with coag current and don't use it slowly.
Very important is you need to know what instrument you're using and what is the thermal spread of every single instrument that we're using.
Right.
What is the vital structure near the area where we are going to use the instrument. These 3 points should always run in our mind before we
I don't use hook because it is erratic. I use the spatula. Spatula because it clearly shows a way for the energy source to go forward. It doesn't allow the energy to go in one at the loop. Like I said, no hook will have to like this. I don't want the energy going this side and this side. So I want to show
much better designed to do it.
And it is like a knife, sharp knife. It just cuts like that, and lateral thermal damage is not even 1 to 2 mm. And always what you said is very true. Staying above I use the word cervical girdle, Vanita. What is cervical girdle is the uterosacral keeping it intact and the fornix being there. So you keep the uterosacral intact, that means you are away from the ureters. And staying inside the uterosacral to do a posture colpotomy, again your ureters are outside. Once you push the bladder down and the ureters are again lateralized. Once you do the posterior broad ligament, and put them aside, again ureters are lateralized. So like I say, it's technology and technique. Don't just say it is technology, but it is technique and technology.
Sure, ma'am. They have to go hand in hand. Very, very important. When in doubt, please recognize the complications on table because most of these are not recognized on table. It's only prevention better than cure really applies here because when you don't recognize them on table, we are going to be caught on the 4th or 5th day when she's going to come with a leak or a fistula. We will be cutting across a very sorry figure in front of her. Not just that, we may also be sued. So a
Yes.
very thorough knowledge of energy sources is important, not just for laparoscopy, because we have extended spectrum even to open surgeries, vaginal surgeries. Today, all of us have started only using energy sources. I think the art of doing suturing and for the pedicles is written off today. Thank you so much, ma'am.
Point I want to add. Like somebody said recently, one of the judgment has come. They said negligent hysterectomy. So for a ureteric injury, it is now going to be called as negligent hysterectomy, and we are going to be sued. Remember that.
So very important. It's sometimes okay to even redo when you have overdo, saying that if you have a doubt, please call the urologist, put a stent. That's also okay, rather than waiting for her to leak on the fourth or fifth time. A thorough knowledge is indispensable. Whenever you are going to practice any form of surgery, it's become mandate today. Thank you so much, ma'am, for all the illustrative videos and making it very safe and simple. Thank you, ma'am. We now move on to the next panel on tackling troubleshooting in laparoscopy and how to make it safe and simple. We have the moderator, Dr. Divya Narasimhan, who's a consultant gynecologist at Bilroth Hospital, Chennai. She is a committee member of the endoscopy committee. Her main field of interest is laparoscopy and advanced hysteroscopy, and she has won the best paper in Oxycon 2010, and she's had a fellowship from Paul's Hospital, Kochi. The co-moderator would be Dr. Tarun Joseph, who's a consultant at Joseph Hospital. He's a high-risk obstetrician and also holds a fellowship in minimal access surgery. And he also has a diploma in advanced laparoscopic surgical anatomy. We have our moderator and the co-moderator who are going to make laparoscopy very safe and simple. Joining them on the panel would be Dr. Meenakshi Sundaram, who's a very eminent endoscopic and robotic surgeon from Apollo Women's Hospital, Chennai, with several publications, authored chapters, and several awards to her credit. The next panelist would be myself, Dr. Vanita from Sunrise Hospital. We have Dr. Niranjan from MS Hospital, Kanchipuram, who was also a freelance laparoscopic gynecologist. I'm sure he is going to tell us more about trouble. Dr. Rupata is not able to join us today. Can we have the next slide, please? Dr. Abdul, who is advanced laparoscopic surgeon and fertility specialist and a robotic surgeon from Apollo Fertility and Apollo Women's Hospital. He has got 13 years of experience and is a member of ISAR, IAG, AAGL, and has been an invited faculty to several national and international conferences. Welcome, Abdul. And we have Dr. Madhumita, who is attached to Apollo Hospitals, Chennai, and she's a member of Foxy, IAG, and AAGL, who is the dear fellow and of Dr. Meenakshi Sundaram, and she has got various prizes for video presentations and quiz competitions. Over to the panelists and the moderator to continue the panel.
Yeah, good evening, everybody. I think we're standing between your dinner and the session. Tarun, are you there?
Yeah, I'm here.
Yeah, okay. I'll just share my screen. Is it seen?
Yes, Divya, I've seen Divya. You can put it in slide. Full screen mode.
Yeah. Now it's good?
Yes, perfect, Divya.
Yeah. Welcome, Meenakshi ma'am. Hi, Dr. Madhu. Panelist there?
Hello.
Yeah, we are here.
Yeah, okay. Hi, Abdul.
Hi.
Hi, Abdul.
Hi.
Hi, Divya, you can
Dr.
hear us?
Niranjan also is there. Is there an echo?
Yeah, I think we can
Except for Rupalata, everybody
I
is
think
there.
Is it okay if I disconnect?
Is there an echo when you talk?
Yes, ma'am.
One second.
Think someone logged in from two devices.
Meenakshi ma'am and Madhu must be.
I've logged out. No. She's logged out. We are only on one device. But if I mute, is it better? Just let me know that.
Then now it's not echoing with you talking. I think Divya.
Hello, ma'am.
Divya's person.
Divya.
Now it's good, right?
Yeah.
Hello?
No, ma'am.
Continue, Divya.
Still I can hear some
Continue,
echo.
Divya.
Hello. I think from Meenakshi ma'am we can hear some echo, ma'am.
Hello?
Meenakshi ma'am, leave.
We had logged in only from one device.
Meenakshi ma'am, leave.
I think if Madhumita ma'am logged in and Meenakshi ma'am log out from her device, it will be
Now there's no
better.
echo, right?
Yeah, now there's no echo.
Now there's no echo.
But the moderator is stuck.
Okay, I think
Divya's connectivity is not good.
Yeah, okay. But anyway, I think she's got some things. Once she gets back on, we'll start with her. But basically what we've got is we just want to discuss some of the practical problems that people can face while doing laparoscopy. Now, a lot of the times we all operate at our own centers and we have everything absolutely perfect. But a lot of the times we also, I think Niranjan will agree, when we go outside, if things are not exactly how we want it to be, it does make things a little bit difficult.
Yeah.
So we wanted to start right at the beginning when we set up your theater. What are the things that you look at when you're starting out your surgery?
Ergonomics.
Yeah, so ergonomics, what kind of, I know we all don't have a gynaec table. What are the points in a gynaec table? What is the difference between a gynaec table and ortho table? I want that to be...
The fulcrum is little towards the head end, if in case it's an ortho table. So it's a little difficult to do in a case of ortho table. So what we can do is we can reverse the table and make sure that the hip is in the head end. So that it becomes like a gynaec table.
Yeah. So what is the problem with the fulcrum being at the head end? Why does
when you give a head low, it goes too high. So you have to lift your shoulders to operate. So the entire ergonomics go bad.
Exactly. Divya?
changing the table head and low end makes quite a lot of difference in these cases.
Yeah. So if you are going to operate on a table that is not, and now if you are in a single specialty hospital, it is going to be a gynaec thing. But if you're in a hospital, and most of us work in specialty hospitals, you need a proper table. So if you don't, tricks like what Niranjan said, turning the table around, otherwise getting a proper stool to get proper height would be very, very important. The other thing is the U for the hip that you want. The ortho table, generally, that proper U that we have at the base may not be there.
Yeah.
While ortho tables have a straight, flat thing, which again makes anteversion, getting the patient right to the edge of the table, very, very important. What else, Divya?
Good anesthetist.
Yes, very, very
One
important.
who's able to give good head lows.
Head low, exactly.
Yeah, proper shoulder support, padding of the joints. And for most of the people who are below normal height like me, we need to have either block heels, which I can carry to every hospital, or a platform to make myself tall and have the patient's abdomen at below my waist, or at least at my waist level.
Yes. So women can men.
The level of patient in regards to the surgeon.
Good camera person.
So I think that's important. But camera person makes your life a whole lot easier. And generally, a camera person is always required when you're operating with a 30-degree scope. The 0-degree scope, you can manage with getting your assistant to holding the camera, but makes things a little bit more difficult. All right. How many of you all know what weight your theater table can hold? What is the weights? Because most doctors, when I go to operate, they know there's a theater table, but they don't know what weight that patient. And now we are getting to a stage where we are operating bigger and bigger.
Yeah, I think when you have tables which can hold bariatric patients, you know that your table can at least hold about 200 kgs weight. So here in Apollo, at least we have tables which are also suited for bariatric patients. So at least our routine surgery patients are fine on those tables.
So gently, the average table can hold anywhere between 120 to 150. But then as we are getting to a point where we're dealing bigger and bigger patients, Vanita madam, what about your theatre?
Yeah, my OT table has something which can hold up to 140 plus. We really tested it with weights because we had one patient, a real huge built African patient who had come in for a vascular surgery, was 142. So I was very, very skeptical. And the OT table we could really manage, but we are very scared about the trolley because putting him on that, we were scared whether we would, break the wheels of the trolley. So we just kept him in the OR itself till 4-5 hours, and then slowly moved him to the wheelchair, and even that was very scary for us. So
That's
all
what
this, actually we need to speak to the person who is selling it. We need to have a check with the brand person, and maybe realistically check it with weights and then do it.
Niranjan, do you always check when you go out and operate? I mean, I know people in corporates will have this option, but people in smaller hospitals, I think yeah. So I think that's the next thing when we're dealing with bigger patients, we have to, because next time the patient is put on, suddenly we can't have the whole table falling over.
Yeah.
Lithotomy, how do you all give your lithotomy? What do you all?
General lithotomy.
So
Generally,
when you
it's
say
a low
extended
lithotomy.
yeah. So Abdul, if you can answer, when you say extended lithotomy, what do you tell your OT staff? That is what I want to know, because I can't go to a new hospital and tell my theatre I want extended lithotomy. What are the points that we look at?
I think if you're doing a hysteroscopic procedure like cannulation or
Laparoscopy, you're doing a hysterectomy.
Yeah, I mean, generally they are two combined procedures. We would change the position of the patient once we finish the hysteroscopy. But for laparoscopy, we need the legs lower down so that when you operate on the left side and the left lower put, your hands don't hit the legs.
Yeah.
And then you need some space. The legs are straight on lithotomy, not too elevated.
Yeah. So the basic thing is Divya, we can't hear you, Divya. You've muted yourself.
Ideally, the angle between the body and the hip joint should be 120 degrees.
Yes.
The angle at the knee, at the popliteal fossa, should be 90 or above. It should not be
exactly.
So that is the basic thing. So if you can say this to your whoever is giving position, or at least watch when they are giving position, that's very important, because many a times we scrub in when everything is painted and draped and you really don't look at these things. But when patients come back post-operatively with pain, numbness, that is when you know that these things are very important.
So I mean, I think even when we are operating, it makes a big difference. Are we echoing again, or is it only me?
Yeah, it's echoing.
No, you're okay, I think.
All right. So that's, I think Meenakshi madam said, extension at the hip joint, flexion at the knee is what we look at. Normal lithotomy, there is an flexion of the hip joint. So telling your staff that the hip joint and the knee joint have to be at the same level. The knee is flexed 90 degrees beyond that. Do you all use any stirrups, cotton? Divya, still can't hear you, Divya. No?
Though people always recommend an Allen stirrups, I think sometimes it's not available in every OT that we go because of the cost. We can use one where you get a good knee support and which extends till the mid leg.
Yeah.
The mid thigh.
So Allen is the best, but cost factor is a huge thing. But there are a lot of Indian brands coming out now with very similar ones. It gives us support from the foot all the way up to the knee. So that way works very, very well. What about your arms? Where are the arms for the patients? Everybody tucks it and anybody keeps it up?
Tucked it, yeah.
Tucked to the side.
Tucked to the side. Any problem with the anesthetist doing that?
Give them a long 100 centimeter three-way extension for them to take the drug.
Yeah. You're the freelancer, so I'm asking you these questions. What do you do if your anesthetist says no? Do you insist? Do you fight with them?
Yeah. Just for that, I fight.
Yeah.
Maybe what they do is they do it in the opposite side. They do the IV in the opposite side so that the assistant can have it extended arm and I can have it tucked in.
But again, do you think that causes nerve injuries? Anyone?
As of now,
No, I think if the anesthetist doesn't agree to have the hands tucked, then they say you can keep it on top, on the side of the head. I think if you do that, then the patient comes back with a lot of shoulder pain and all that. So we generally don't do that, and we tell the anesthetist also we are not very comfortable with that.
Exactly. So
A
I think
proper extension at the shoulder is something we must avoid. Rather than that, it's better to just put it like how we put for our cesarean, put a good armrest and then just allow it and strap it.
on the side. Yeah. So I think this is
Ask the camera person to stand the other side of the hand, and we stand with our boundaries. The hand acts as a boundary between the surgeon and the camera person.
No, though we all say this, I think practically this is a problem
It's
that a lot
very
of
difficult to operate like
yeah.
that.
So I think a lot of doctors face this issue where they get the arms, the anesthetist doesn't agree, but I think we have to insist on it when we operate. Divya, are you here?
First and foremost, we need to educate our people for laparoscopy. It's always better to start the line on the right hand rather than doing it on the left hand.
Unless you're a lefty.
Yeah.
So do you have
The thing is, you can strap the arm over the shoulder, over the chest. If the anesthetist is very particular of having the axis very close to them, like the IV axis, you can just strap it across the chest, which what we used to do earlier, if they are not agreeing to strap by this side.
when we strap the hand on the side, do you find any problems with the hand as such? Because sometimes they tuck in so deep inside that the buttock is continuously resting on the wrist. And one of our patients had a wrist drop surgery, and slowly what happened is that's the second time. So that is very important not to strap operation of the hand until once it is started.
We are not able to hear you.
We need to properly pad the fingers also so that there's no undue pressure and there's no contact to the metals. So all these things need to be avoided when we tuck the...
I think that's where the entire team approach comes. You need to train the theater assistant, your nurses, your anesthetist, your assistant surgeon, and as well as the operating surgeon. So your entire team is aware of what you require and what is proper ergonomics, what is good for the patient as well as for the surgeon.
Yeah.
Divya? Divya, are you there?
I think she's some problem with the guy. What about the surgeon, madam? Any particular position?
Right-handed surgeon always stands on the left of the patient, but there are some times, like when you have want to suture or something, there's nothing wrong with standing on the right of the patient.
Lot of it. Okay. Moving on. How many of you all use a pneumatic compression device? Do you all use stockings, or what do you all do? Anyone? What do you
Depends on the duration of the surgery.
We regularly use TED stockings, and if the patient is too heavy, we also put them on floatron.
The floatron, but it's a pneumatic. Yeah. How long do you continue that?
As long as the patient gets mobilized, 6 hours until the patient gets mobilized. After we start orals, we mobilize the patient actually. At least bed mobilization we do. Until then, we put the pneumo. And if it's a very obese patient, until we give the Clexane shot, at least we continue the this thing until she stays in the recovery.
Done. All right. Okay, move to entry. What are your preferred entry methods? You can take
Li Huang point.
Li Huang point for everybody?
Yeah, most probably. Unless it's a very small uterus, then I'll go just above umbilicus, or else most probably it's Li Huang's, which I always prefer.
And you do direct entry varies?
What?
Direct entry or varies?
Direct entry.
All right. The others?
Supra-umbilical
entry.
Very. Okay.
Really, that Palmer's is what we always do.
And then, so that's an extra incision you all put there?
It's a 2 mm incision only for the VDs to go in.
Okay.
In case it's a robotic case, we can convert that into a 5 mm for the assistant.
All right, done. Now, Any of you use the optical trocar or open it?
Yeah, sometimes when you have a scarred abdomen and you want to do an undervision entry, we sometimes use optical trocars.
Okay.
Not a routine use, very few selected cases.
All right. Now, if your varies, you put your varies inside, you've got your insufflation. If you're not able to enter the varies, what do you do?
Maybe that is the time I would just go in with the direct entry.
At what point?
Depends. If I've had multiple entries and I suspect a preperitoneal insufflation, I would not go at the same point. So, for example, if it happens supraumbilical, I would take it at the Palmer's or the Jane point.
All right. Divya, are you here?
I think she's having some trouble
you
with the
hear me?
connection. Yeah,
Can you hear me?
much better without echoing.
Oh, super.
Now it's gone.
It's paused.
Okay, no.
Reading audio, if it's on, I think it's echoing every time.
Yeah, I think you should just off your video.
All right.
Now it's okay, right?
Yes, without the video, it's better.
Okay, fine. Let's go ahead.
Go ahead, Divya.
Yeah. So if you have a failed varies, some of us do the varies technique only. If you had 2 or 3 attempts of failed varies at the umbilicus, what would be your next step?
We discussed that already.
Abdul, what would you do?
Failed varies, I use a blunt direct entry. I mean, blunt trocar and direct entry. Usually, if it's so I go usually through supraumbilical area, and I fail to establish pneumoperitoneum, then I go to the Palmas and do a 5 mm blunt trocar entry.
All right. So
sometimes with these failed varies, we have a lot of preperitoneal insufflation, Dr. Niranjan. How will we tackle that, or how will we get rid of that preperitoneal insufflation?
So far, I've not faced it because I've always used direct trocar entry, right?
Direct trocar entry. Okay.
So what we do is when we have a lot of preperitoneal gas, then we just continue with the surgery. The intra-abdominal pressure, once you have a proper pneumoperitoneum, takes care of the preperitoneal gas itself. And then once you're done with the surgery, you see that there's no preperitoneal gas at all.
The first and foremost thing is when you've connected your gas inlet to the varies needle, you always need to look at it whether it's in the right place before you continue the insufflation for a longer period of time for you to tend the peritoneum down. So when in suspicion, please do not continue to do the inlet and insufflate the gas. Just stop short there. That is the time maybe your optical trocars or other things can help you in entry. Or sometimes if inadvertently you have done, you can leave the varies at the same point connected to the suction, though not going to be of very great use, but theoretically they say it sucks out some amount of gas.
Divya, next slide. So the next slide. Yeah. So you've put your varies in, you had a failed entry, now you've gone in and you have something like this. Which the video I think was just a video. There's a picture.
Just an image.
The varies needle injury has now gone right through and through your bowel.
The first instinct is not to remove the varies from there when you suspect something. It's sometimes better, like to even go through that simple test of hanging drop, aspiration and all that. When you've gone something through this, you may encounter little blood or something yellow also may come. So first very important thing is to leave it in place, enter through another entry and identify the area of injury and tackle it then before you go to the main proper surgery. See, many times what we do is when we know that it's not the right point, our human instinct is to pull it out and just cover up. Once you have done that, it's very difficult, especially the varies, to go back and see where you have injured.
Okay, would you suture it right away, ma'am, or would you want someone else to help you out?
Varies, I think we really can handle it ourselves, especially this looks like a small bubble, we can handle it ourselves.
All right. No, but this is always
the suture material you use to close the
30 vicryl double layer suturing. See to that you don't cause a stenosis. That's the way you'll have to do. Suture both the entry wound and the exit wound.
Yeah.
Yeah, that's important.
Do
Entry
you
wound
think,
and exit wound.
ma'am, do you think this is a problem with the varies? You happily enter and you just pull it out. An injury like
It's
this
very
could have
difficult to have a through and through injury like this with only a varies. You could have something like this with a 5 mm sharp trocar entry, but to have a varies through and through like this is very, very difficult unless you have a small bowel plastered on the abdomen, like a TB abdomen, where there is a flat plastered abdomen where you have put in the varies. This must be mostly, your varies going under the vicinity of the small bowel is what I feel.
Yeah. No, but that is always my worry with blind and with the varies. You like I said, most of us can just pull it out, and then we won't know what's happening.
If it is a varies even entry into the stomach, if it is just at one point, I think you can just leave it alone.
That's you. Yeah.
So does anyone do an optical trocar entry?
If we can't get it via various,
Yes.
Dr.
if
Abdul,
we
can you
cannot
walk?
get into
Dr. Abdul, can you walk? Nick?
Optical trocar, I don't normally use optical trocars, but I think we have ones with a disposable where you're supposed to use the 0 degree and lock the scope inside the optical trocar and then use the trocar as well as the scope to gently do screwing movements and then visualize each layer of the abdomen as you go through. And then once you see the transparent layer, that's the peritoneum, and then you go in and enter into the abdomen.
This is very useful, especially when we have a large ovarian cyst or something like that. We don't want to directly go and puncture inside. This optical trocar helps a lot. Yeah. Coming next to how we are going to manipulate the uterus. Each of us have a very different way of doing the manipulation. Dr. Vanitha, ma'am?
I use a myoma screw generally. I do not use a manipulator from below. Maybe very few areas where I would use a manipulator from below would be when I do a circlage. Very rarely I use one from below. Otherwise, it's always my favorite has always been the myoma screw.
Meenakshi, ma'am, what do you use? Screw?
Manipulator. Myoma spiral for laparoscopy, roomy manipulator for robotic.
Okay. Fine. But sometimes we end up using both.
Yeah, sometimes in cases of endometriosis, if I want to delineate the POD or I want to delineate in previous multiple sections, if I want to see where the vault margin is, in addition to the myoma spiral, we sometimes use just the colpotomizer. You just probably need to see where the vaginal ring is if you want to make an entry.
Yeah, in such cases, a bill and colpotomizer could be useful, or even a simple gauze put on a sponge holder and just putting in one of the posterior chronic can be useful.
Also, in case of an endometrial CA where manipulator or the screw cannot be used, we can take a bite with a vicryl on the cord nose and we can hold that using a needle holder and use that for manipulation. We did a case like that.
Okay. When we do a lot of bleeding like this, once we use a myoma screw, how do we control the bleeding, ma'am?
To avoid multiple incursions of myoma is very important. And as you approve, just use a bipolar cotton in the area. If the bleeding is going to be torrential, especially like the TNF cannot bother. But in the myoma or something, under
So one thing is we always
minimizing multiple pokes is important.
Yeah. And also, first of all, many a times we use vasopressin on the surface before putting in the myoma spiral. So that itself kind of reduces the, myoma site entry bleed. If you have, usually only when you're changing the position for manipulation it will happen. Keep your bipolar ready, so when you take this out you can do bipolar on that surface and
And not
change the
necessary to screw
positions.
all the 3 or 4 spirals inside. You just need to leverage it out. You don't have to push it till the endometrium.
So I was a person who was continuously using manipulator, but sometimes when we use the myoma screw along with the manipulator, what happens is they are not acting in correlation, and they are totally doing a different job. So at that time, the most important thing is to relax the manipulator and use a myoma screw, and only when we are going to the vaginal wall cutting, involve both in the surgery. So combined approach we need to be a little careful.
If you're using a manipulator, I mean, if you're using a myoma spiral, you should only use the colpotomizer. You really don't need a manipulator. If it is a combined approach, it should be a myoma spiral with only a colpotomizer. You only want to delineate the vagina, because moving the uterus this side, that's it, the manipulation is done with your spiral. But if you try and use the manipulator along with the myoma spiral, then it is a problem.
A lot of coordination between the vaginal and the laparoscopic assistance is sometimes not feasible at all.
So coming to the next other practical difficulty which we face, Dr. Manjula madam clearly explained about how to take care of the cautery and how to use the monopolar safely, how to use the bipolar safely. She was continuously telling us about the settings of the pure monopolar cutting being around 35 to 40 or 45 maximum, and also to use the bipolar at a setting of 35 to 40. Sometimes we do encounter such burns. What is the most important thing which we have to look out when we're doing the surgery to prevent this kind of an injury? Dr. Abdul or Dr. Niranjan?
I think the return plate should be fixed properly.
So when does the return plate usually move out?
If you keep reusing the plate again and again, disposable plates are also reused now. And you have to put it in the proper place.
Not over the promontory.
Yeah.
So when we reposition the patient in the head low, the cautery plate sometimes, the return plate sometimes move.
So what we normally use is the disposable adhesive plates which we put on the thighs. So we generally don't have this issue during repositioning. Only when you have those black plates which you have kept under the patient's bottom, and then you are changing the position, it's a problem. When you use these adhesive return electrodes, you don't generally have that problem. So like you said, when you are repositioning with the black plates, you definitely have to ensure that it is fully in contact with the body when you are changing positions.
Most of the time, freelance laparoscopic surgeons, we have this problem because we operate in different theaters where the generators also are different type. The recent generators have isolated units where the current doesn't even flow when the return plate is not properly placed. But the older ones, the current, like when you try to operate with the monopolar and you just try to keep on trying to work on it and you don't get the current flow, that's a time where you really cannot keep increasing the setting. You need to really think whether the return is going properly. So these are all things. First thing, when you start as a freelance surgeon, you have to look at what generator it is, what are the settings to be kept properly, whether the return plate is kept properly grounded, in contact with the patient, does it have any contact to the metal? All these really needs to be done very meticulously for us to avoid these sort of burns.
One important thing is sometimes when we have serviced the machine, this particular patient, we had it after we serviced the machine. We thought we increased the current setting a little more, and we were never thinking about this grounding somewhere else. We were thinking that the machine is not working. We slightly increased the power setting every now and then. We didn't realize that when you raise the power, the cutting energy also will raise, and you need to see a proportionate increase in the cutting in the laparoscopy. If you feel that there's a discrepancy, it means that in spite of increasing the current, you're not able to cut the wall properly. It means that it's earthing somewhere else and you need to look out for these burns. If it does happen, how do we manage, Meenakshi ma'am?
If there is a burn, most
Yeah,
of the
if
time
there is a
burns
burn.
are recognized when the patient is off the table and comes back to you for a follow-up in your OPD. They suddenly complain of something that is, hurting. You just give, ointments. If it is very severe, then you can, consider excision or send it to your plastic surgeon to do the needful.
If you
see
it at the end of procedure,
then you freshen the edges. So it's a fresh burn. You can just freshen that diathermized edges or cauterized edges and apply sulfadiazine and put a dressing. It depends on the depth of the burn also. If it's a superficial burn, generally you don't need to do anything much. You need to give them a good dressing.
So that's very important. We need to freshen the edges.
So that's
and
very
then
important.
bring
We
it
need to freshen
approximation.
the edges and then bring it to approximation.
We've interestingly had the tips of harmonic is so hot that when you place it on the patient's thigh after using, and if it is like if your drapes are it can go pierce through and through the drape, and it has pierced the patient's thigh also. That you
I've
should be
had
very,
one
very careful.
case where
I've
the
had
light
one
source
case
had
where the
burnt
light
the
source
patient's
has
face.
burnt the patient's face.
Yeah,
So
light
it was
source can
actually a case
also
of
burn
So it
the
was
hysteroscopic
actually a
drapes.
case
installation.
of hysteroscopic installation.
So we had another
So
camera
we
light
had
source
another
here
camera
also.
light source there also.
So I think the
So I
assistant
think
had
the
kept it
assistant had
underneath.
kept it under
We had a scar on
We
the
had a
patient's
scar
face.
on the patient's face.
So the most important thing is you have to keep the light source off. It can't be on the patient's face, or you hold it in your hand. Ideally is to just put it off if you're not in using it.
A very
A
valid
very valid
point.
point is this.
Yeah. Let's run our next video. We want you to look closely and see where the bleeding is from. How could we have prevented this, and how do we manage this? Ma'am, can we?
You can't see the video playing.
Is the video playing?
Yeah, it's playing in very.
It's buffering a lot.
Yeah, it's buffering a lot.
I think basically the message here is the pedicle is taken very, very close to the uterus. You need to stay a little away from the uterus. And second thing is, between the convolvulus, there can be a lot of veins that are retracting, so that also you should take properly when you're taking the convolvulus.
Is it playing now?
Yeah, but at a very
Perfect.
slow rate.
Yeah.
It's in 0.5x.
So the most important thing here is the round ligament should be cut properly, cauterized and cut properly before we open both the leaves of the broad ligament. Only then we'll be able to get the planes properly. And we saw that in the earlier part, the visualization wasn't that good. Maintaining it in the correct plane, like not too medial or too lateral, is very important when we are entering the broad ligament. and also opening the UV, cutting the opposite round ligament, opening the UV fold and pushing the bladder down will prevent us from going straight into the uterine artery also. Because if we go straight into the uterine artery, sometimes without the bladder being dissected, when we hold the uterine artery, we tend to go closer to the ureter. So can we suture this rather than go on cauterizing it, Dr. Vanitha ma'am?
Suturing for the no, I'm still not very clear with the video. Is it a bleeder from the level of the round ligament, or is it the uterine vessel that's
From
bleeding?
From the uterine.
Yeah, what I would do is see, I see only one port being used from the left side. I would definitely get my lower port. I would say get a grab of the bleeding vessel with the left and then do a suctioning. If I am able to do the anterior leaf of the broad ligament, push the bladder a little, then maybe I would use a clip, not suture at this point of time. I would use a clip.
So we should all learn how to apply the Hemolock clips and the smaller clips, and also suturing should also come in handy. Ma'am, have we reached the time? 8:45.
No, we're already post time. You can take another 5-10 minutes to finish.
Another 5-10 minutes to finish.
Okay, fine. So what are your experiences, Vanitha ma'am, with port site infection?
With port site infection?
See, as a freelancer, which I was 2 years back, this was definitely a nightmare because you would have operated, the patient would have gone home happily, and then after 4-6 weeks, you get a call from the consultant saying that there is one modulator site which is, like having some sort of discharge, and you will not know what to do. That is the time by the time the patient comes to you itself, there would have been multiple opinions, multiple antibiotic usages, and some people even lay open the tract, some people do an IND, all that is there. So when way of preventing all these port site infection is to do a proper sterilization of your trocars, which becomes very mandatory even in freelance practice.
So do you do this injection of streptomycin, gentamicin at the local site along with the local?
General
Does it
surgeons
give
do
any
claim a
difference?
lot of importance on injecting 1 gram amikacin at the port sites, but I have personally not followed it.
So it's not of much use. Do you think using a sleeve on top of that morcellator sometimes reduces the chance of infection?
A proper ETO sterilization is what will
Yes.
help you.
So that's what we wanted to bring out. So no point in using streptomycin, gentamicin over there. No point in using those vaginal probe covers sterile covers on top of it and doing it. It's the proper ETO or sterilization that will help you to prevent this kind of infection. Mostly it's around these morcellators when we hire them for services, and it's not our own thing. And if it does occur, how would be the management, ma'am? Do we go ahead, lay it open, or do we give a chronic treatment with antitubercular for a long time? What is your experience with this? Anyone?
It's an anti-tuberculous treatment is better if in case it's atypical mycobacterium.
Yeah, the second line drugs are more preferred, like clarithromycin, ciprofloxacin.
Linezolid.
So rather than going and doing a surgery again, a long-term antitubercular treatment will help.
Antitubercular treatment will help.
We need to differentiate a primary port site infection from a atypical one. If she's going to get it in the first 7 days, it's a primary infection. We deal it with antibiotics.
Primary infection, we deal it with antibiotics
later. We need to take it more like an atypical. We need to take it more like an atypical, and we need that have been there and just propped up to give us the infection. So even when tested negative, it is better to give her a long course. Drink 21. It is better to give her a long course. Drink 21. Sometimes running even up to 3 months.
Sometimes running even up to 3 months.
9 months. Ma'am, this atypical we had actually 2 cases in Apollo. Atypical microorganisms do not respond very well to ATT also. Even the extended 9 months ATT, they don't respond well. These people come back again and again with the infection. So excision and then putting them on precautionary ATT is the solution.
Yeah,
For
once they
the
have a
infectious disease,
properly
Yeah,
formed
once they
sinus
have a
tract, better
properly
to
formed sinus tract, better to it.
Sometimes we have
Sometimes
multiple
we have
folds
Divya, if you're
having
multiple
them
trying to
folds
also.
talk,
having them
Divya, you're
also.
on mute.
Yeah, I muted myself thinking that
Yeah, I
I'm the reason
muted
for the
myself
echo.
thinking that I'm the reason for the echo.
You are.
See, very, very important that there's no replacement for proper sterilization of instruments, and people just put it into Sidex and take it the second minute. That already Sidex is only a high level disinfectant, it's not sterilization. Soaking it there properly for 20 minutes, and before soaking it, immediately, the process of cleansing starts from the table itself. Once it's out of the abdomen, the blood needs to be wiped, and then you need to put it in an enzyme solution, wipe away all the blood clots, remove them, and if you have ultrasonic oscillator, then it's better to put it in that. Take multiple steps, wash it properly, air dry it, and then it goes for your either Sidex dips or for your Sterard or ETO, whichever you're able to do. Once you're going to have a Sidex only as the method of sterilization in your hospital, remember it's only high level disinfection. So you need to have the Sidex strips also, because it is not 15 days, which is always to be kept as the, like cutoff. It is the number of dips, the dilution that happens every time you put a wet instrument. All these also needs to be kept in mind. You have those strips which you can dip before every insertion, and if it turns violet, still the potency is there. If it doesn't turn violet, it's time for us to change it, even if it's on the 5th or 6th day. All these have to be kept in mind to, reduce this complication, because once it comes, it is definitely a headache to the patient as well as to the surgeon.
Yeah, I think we'll conclude, Anita ma'am, with a closing statement.
Yes.
Yeah.
Thank you so much, Divya and Tarun, for covering all the troubleshooting and minor points. Generally not
Generally
discussed in
not
most of the
discussed in
conferences,
most of the
but hold a very great
conferences,
importance in
very
day-to-day
great
practice.
important day to day.
So we are
I hope the panelists we
lot of
also
practical difficulties
contributed
and
to
troubleshooting.
Practical difficulties and troubleshooting.
May I now request Dr. Meenakshi
May
to
I
give
now
the vote of
request
thanks?
Dr. Meenakshi to give the vote of thanks?
It was a very, very interesting, useful, very practical session. Really thank our sir and Manjula madam, who have given us wonderful tips for our routine surgeries. And thanks to our moderators Tarun and Divya for making this panel extremely simple, interactive, and very practical. I think anybody who is freelancing or starting to do laparoscopy will have all these itches and good points being brought out by all the panelists. So, on behalf of the endoscopy and laparoscopy and robotic committee of OGSSI, we would like to thank each and every one of you who've been a part of this webinar, and I hope that this some hope seems to have gone off. Can you hear us?
Yeah, I can hear somebody, but I'm not able to
I can hear somebody, but I'm not able to
identify whose voice
No,
it
it
is.
was.
identify whose voice it is.
No, you heard the Thanksgiving, no?
Yeah.
Yeah.
Thank you, Meenakshi.
Thank you, Meenakshi.
Thanks to all the delegates who were
Thanks to
there,
all the delegates who were there,
made this webinar successful.
made
Thank
this
you.
webinar successful.